All right, everybody. Hello. Happy Thursday. It's a special treat today, coming live to you from not so much San Francisco, but mainly St. Louis, Missouri, icy cold St. Louis, Missouri. Because today I feel like it is a little bit of a setup where we have somebody in the lukewarm seat, but intimately linked to the person who is presenting the case. So I feel like I should introduce them both together. And their introduction is a very special one because um, that the combination of Noah and Marcella actually was probably the inception of the CP Solvers Academy. If you're unfamiliar with the Academy, it's a place where folks who come to VMR regularly are sucked into the vortex of focusing in on clinical reasoning and building community even more so than VMR. And these are the people who you see facilitating, discussing, scribing, and doing teaching points. And so the story of the Academy is one of an accident where Marcelo, who had been and still is a longstanding team member, who has done so many things in the realm of CP solvers, it would be silly to try to list them or enumerate them. But she and Noah shared physical space and somehow we tumbled into the idea of doing our first sort of behind the scenes private session where Noah, who is presenting a case today, wowed us with a case of GPA and, of course, his personality and his knowledge. And so that literally was the initiator of what has now been a remarkable cascade of over 75 Academy members who have created podcasts, schemas, helped each other with the match, um, continue to build community on a near daily basis. We do our own sessions behind the scenes almost daily. I'd say maybe sometimes even twice a day. So I feel like today is a mini celebration of these two wonderful people and what they helped create. Of course, Marcella is probably going to be a little bit more nervous side of that task with discussing today, and Noah will be presenting. So maybe I'll hand the mic to you guys, Marcella first, and then Noah to say hello, and then we'll thank the people who are making it happen thereafter. So, mic to you, Marcella.
Thank you so much, Rabih, for such a kind introduction. I'm really happy to be here today. It has been a while, so I'm nervous, especially because Noah has been telling me for the past month that this is like the hardest case that he has seen. Um, so, but I'm so happy that I'm not even thinking about that. So I am a PGY2 here at Washington University in St. Louis. I'm very happy to be here and happy to be here with you all and to share this space. And I'll pass the mic to Noah. We were actually planning to be together, but I think it would be kind of like weird. I don't know. So he went home.
Yeah, Marcela, Marcela's getting ready to start her workday. I just came back from nights, so I'm home. That's why my place is dark. And it's kind of crazy to think that 2 years ago is when I reached out to Marcela, asking her if I could, if she could set me up to present a case in the clinical problem solvers. And just yesterday, I was laying on her floor while she helped stretch my hamstrings. And we're actually expecting a academy member today is coming to visit us. Mariana will come to visit St. Louis. So it's so wonderful and so lovely, the friends and the family that we build through CP Silvers. And I'm super excited to present this case today. It's going to be a treat.
In true friendship fashion, you've saved the hardest case for your closest friend, huh? I love it. That makes a ton of sense. Well, I'm so glad I get to be a byproduct of that enjoyment. But it wouldn't be possible today without two people who are making this happen. The first is a last minute hero who jumped in to do the scribing today. Lyra, I'll hand the mic to you to say hello.
Hi everyone. I just woke up from the nap.
Oh
So I hope I'm gonna do a good job scribing for Noah's case. I feel like it's gonna be intense one.
no. It's gonna be you don't need any coffee anymore, that's for sure. Thank you so much, Lyra. And then I'll hand the mic to Selsan to say hello.
Hi everyone. So happy to be here and to do teaching points, and I'm excited for Marcella's discussion and Noah's case, especially that I've learned a lot from Noah's case presentation skills. So looking forward to your case, Noah.
Alrighty, guys, that's awesome. We got all the prep out of the way. Let's rock and roll.
Okay, so this case starts in the ED. You're looking at the track board, it's a very busy day, and you see a 30-year-old female comes in, and the chief complaint is like fevers for 5 days. So you go talk to her, and she tells you, "Hey, Dr. Marcela, I'm having fevers for like a week. I'm just feeling overall very fatigued. I'm also having a lot of joint pain. And then 2 days ago, I started having some diarrhea, nausea, vomiting. I do have contact with some kids at home, and they all kind of have the flu. And I decided to come in because I was just feeling very bad."
Oh, Dr. Marcela, since you're seeing this patient, I'm really curious. What are you thinking with this information so far?
Okay, so at first I'm very excited because I see fever, and as you might know, I like ID. I'm excited to see what this is going to turn out to be. So first I'm looking at the patient and I see that she's a 30-year-old female. So that makes me think more towards something like an infection, or especially because it's acute. So every time that I look at fever, I remember one case where Reza was discussing and the RLR, that at first you have to think, is it like really fever or is it like elevated temperature? So looking at this chief complaint, I think it's really fever because of the timing and because of the other signs that she's complaining. That makes me think more towards like inflammation. So then when I start thinking about fever, I like to use the IMA mnemonic. So first infection, and then for base rate, I think infection is more likely in this case, because of the timing of the presentation, because of her age, and because of symptoms like flu-like symptoms. But you cannot not think about other things like autoimmune, especially she's a female. She's presenting with that for now, but this can extend, and she has arthralgias and other things. But going through the IMA, you also have M for malignancy, so you can think about that, but I would keep that in the back of my mind. I also think about drugs, which has been taking anything different. And then you can think about like endocrine or other things, which I think is less likely here. So that's like for talking about the fever. I feel that's going towards like an acute to a subacute presentation now. That's turning to like 7 days. Um, since she has also like arthralgias, headache, flu-like symptoms, and she's exposed to children, so I'm thinking more towards like a viral type of illness. But I would also be curious to see how she's looking like in terms of vitals, and go from there. What do you think, Rabih?
I'm right there with you. I think that's such a comprehensive analysis of what fever represents, either hyperthermia or true inflammation. And the operating assumption in most instances is that this is really truly a elevated core body temperature. And I think the question really in a situation like this is, how much do you have to think, and how much cognitive energy do you have to exert towards a young, presumably so far otherwise healthy person with flu-like symptoms? And I think the hard part in the emergency room is to ask yourself, how much mental resources do you divert in this situation versus the many other patients you have? And I think what's really powerful about viral infections, including the flu, is the amount of discomfort the patient has is extremely high compared to the amount of dysfunction that they have, with dysfunction here defined as the ability to eat, talk, or walk. And so what all of us have likely felt is debilitating symptoms that leave us unable to go to work, leave us uncomfortable, but leave us really almost imperceptible to the eye of our colleagues or neighbors, who can't even tell how bad we're feeling because we can eat, walk, and talk just fine. And so for me, what I would try to establish in real life right now is how much dysfunction has she had? How much is she able to eat? How much is she able to walk? And how much is she able to talk? And if none of those things are really profound, then I would probably say, well, hey, let me do a quick exam and let me get a viral swab and see what I find. And if I find something, I'm done. And that's all the entirety of this journey, which of course will not be the case today, but I think will probably be the case in real life. So the biggest thing I think whenever you're dealing with flu-like symptoms is to really try to figure out how much dysfunction is the patient having. And I'm really, really curious to see that. that of course is coming with the big assumption that the patient is not immunocompromised and does not have any unique exposure. And so if those two things are opened by Noah, who tells us that she's recently been vacationing in the Amazonian jungle, then I think we might have to change our calculus a little bit. All right, Noah, Mike, to you.
Yeah, I was withholding a little bit of information. So you do look at her chart and you see that she has heart failure with reduced ejection fraction. She had an ICD placed in the past. She has this diagnosis of SLE, lupus, and her SLE was complicated by end-stage renal disease. And she actually got a renal transplant 2 months ago. And after her renal transplant, she was found to have donor-specific autoantibodies, which was concerning for a reaction called Immunosuppressed post-transplant response that was treated with IVIG, rituximab, steroids, and thymoglobulin. She also required plasmapheresis a month ago. She's on mycophenolate, prednisone taper, tacrolimus, Bactrin, and valganciclovir because the donor was CMV positive and she was CMV negative. And as far as dysfunction goes, she's feeling pretty good. This feels just like a regular flu to her, but she was actually instructed to come in by her transplant nephrologist.
Oh, withholding were you, huh? Oh my gosh. Yeah, Marcela, what happened to your calculus now?
So it changes a lot now, the way that I'm thinking and how I'm concerned about this patient. I feel that every time that I'm thinking about infection, I'm thinking like, who is the host and what is going on? And for this presentation, the who is like very important to me because she's a patient that is immunosuppressed, not only because like she has the lupus and now she has this transplant. So it put her in risk of a lot of different things in terms of infection, but in terms of like reactions. And we know that she already had this donor specific antibody. Right now I start thinking more towards like atypical infections as well. And I would do more like a broad workup than I would do for another person. And I also would have a lower threshold to admit her just to keep an eye on her and see what she was going to manifest next. So I'm glad that she came to the hospital, even though she's overall feeling okay. And I would be kind of doing more like a broad workup for her because of that.
Yeah, I'm right there with you. I think that what you essentially emphasized is that the range of possibilities is way, way more. And the need for you to expand your workup has increased dramatically. And I think the fundamental difference is, even though she has no evidence of dysfunction right now, the risk of this process not being able to be contained by the immune system is much higher than anybody else. And I think fundamentally, what really changes in an immunocompromised host with a flu-like illness is in many patients who are immunocompetent, who have a flu-like illness, we don't end up with a very specific diagnosis. We'd be very comfortable if they are are mildly ill and have negative viral swabs, and we say, hey, this will probably get better. We're not sure what it is. I think the need for diagnostic certainty or a tremendous effort to get diagnostic certainty is nearly 100% in a patient this immunocompromised. So if you ask yourself, if Noah didn't give us this history and this patient didn't have any dysfunction, even if her COVID, flu, RSV, or viral swab was negative, we would probably say, you know what, go home and we'll see how you feel in a few days. I don't think this is a reasonable option in a patient who's this deeply immunosuppressed. And so I think that I'm curious, Marcela, now that you mentioned we have to do a broad workup. Of course, the exam will give us a sense of potentially what's going on. But I'm curious, how do you think your workup broadens in a practical perspective? At first glance, what might you be more inclined to get from the very get-go?
So at first I will look her basic labs that probably they did already collected just to see if she has like new renal dysfunction and other things. But one thing that for transplant patients, I would have kind of like a low threshold to get PCRs. So for example, CMV, PCR, BK virals, other things, especially because she's presenting with this something that looks like more a viral illness, and we know that her donor was CMV positive. So that would be something that I usually don't do for someone that doesn't have an immunosuppression, especially because I expect them to be better. But for her, I expect that to be like different, and I would not trust as much serologies for her because of that. So I think that would be the main thing, and I would make sure that I get like blood cultures for her, and all the other things that I could do for other patients. But like you mentioned, if it was a patient that didn't have this past medical history, I'll probably just send them home with precautions and see what they would present next.
I think that's so well articulated. I think fundamentally, the workup is much more enriched and deeper in these patients, but actually is analogous to what you might do in an immunocompetent host, but it's different in really two fundamental ways. I think the first way it's different is you realize that a systemic syndrome like this, she is, we would think in an immunocompetent person that they're viremic and that they have COVID or flu circulating in their blood, and that's why they feel achy and poor. But we don't really care to prove that in the blood. We just swab the mucosal site and we're done. But I think we recognize that the reason that a patient who is immunocompetent with COVID feels systemically unwell is they have virus circulating in their blood. But I think what's fundamentally different in an immunocompromised host is the range of possible viruses in the blood is now much wider, including viruses that don't localize to a specific mucosal site like a CMV or like BK virus. But I think what we try to do, as you said, is to send the blood for as many tests as we can conceive reasonable, especially blood cultures and viral testing. And the viral testing tends not to be, I think that in a renal transplant patient, BK virus is important. CMV virus is probably important in every patient, but that and maybe parvovirus are the only viruses that I think you would send up front if you were be inclined to send them up front. But the other dimension of it is also to really recognize that you may be fooled into thinking that this is a systemic syndrome in the blood, but actually is a focal syndrome that the patient can't localize. And the reason they can't localize it is because they are immunosuppressed. So I think fundamentally if you watch from a distance what happens to an immunocompromised patient who's getting a workup, there are many more blood draws looking at blood-based pathogens, especially blood cultures, some viruses. But there's also a lot of leaning on the radiologist to be able to be like, wait, she's not telling me where this infection is. And since she has no idea, I'm going to assume it's everywhere in her body, i.e. in the blood. But she may not be able to tell me that her kidney on the right side is stranding. And so we have a much, much, much lower threshold for cross-sectional imaging in these patients because we recognize that the absence of focality on history and exam may not represent the true absence of focality, may represent the patient's lack of immune system to be able to sing off the alarm bells and let us know. So I think, the odds of her not getting cross-sectional imaging are very, very low. So like you said, there's two fundamental differences. There's a much deeper dive into blood-borne infections or blood-based infections. And there is a much wider recognition that the absence of focality doesn't always mean there is no focality, and leaning on radiology is really key. But let's see what Noah has in terms of the next aliquot to see where you go.
That was beautiful, both by you and by Marcela. I love this discussion. So for a physical exam, reassuringly, her vitals were pretty much stable. She had like a mild tachycardia to 110. She had good blood pressures, like 120/80. She's afebrile at the moment of the exam, but she didn't have documented fevers at home. She did measure it. Review of system, I think someone was asking in the chat, was like pen negative. That's all the symptoms that she had. She didn't have any headache with like movement. She didn't have any focal neuro symptoms. She didn't have any major cough. She had some rhinorrhea, but not major cough. No shortness of breath. Physical exam was largely non-focal too. She just looked a little bit uncomfortable. And even her arthralgia sites weren't arthritic on physical exam. So the ED kind of did the initial workup. They got a CMP, they got a CBC. The CMP was stable. Her creatinine was 1.3, which is kind of unchanged from her most recent admission. And then her CBC showed a white blood cell count of 0.9, so 0.6 neutrophils, 0.1 lymphocytes. Her hemoglobin was 8.1, which is around her baseline. Her platelets are 69 from 150 about a month ago. The ED also got cross-sectional imaging, CT, chest, abdomen, pelvis with contrast on arrival because of the non-focality given the marked immunosuppression and the neutropenia. And it was really only positive for bilateral renal masses, which were very suspicious for RCC, enlarging moderate splenomegaly, no lymphadenopathy, no pulmonary process, no fat stranding suggestive of any inflammatory foci.
Wow, this Swiss Marcella has a lot of interesting information here. What caught your eye?
So at first, I'm happy that her vitals are stable, but I am also going to keep a close eye into her. The next thing that makes me concerned first is the neutropenia, because that's something that we need to like act on. So for that, she has a febrile neutropenia now, so that would be a reason for admission for me, and would be a reason for me to just like start treatment before I finish like thinking about what she has. So for that, I would start like antibiotics and keep a close eye to her, especially because now she's like 600 neutrophils. She's almost close to severe neutropenia. And then I would think next she has pancytopenia. So for that, I would start thinking about like why she has pancytopenia and use that as a clue next in my differential diagnosis. Is it because she's like maybe her bone marrow is affected? Is it because of medications, or is it because of the infection that we think she has? Or is it an autoimmune process that's causing the pancytopenia? I would also take a look at her labs to see if something like I see that her baseline seems the platelets before were better, so it seems to be something new. And then I would think about doing that workup that we initially mentioned, because some of those virus like parvovirus could cause the arthralgias and pancytopenia and other things. And then next, when I see the CT, I'm concerned about these renal masses. They mentioned it's suspicious for ICC. I would not think that that could explain what is going on with her, but I would be concerned if maybe those masses could be something else, and it could be related or not, if it's like signal or noise in this case. And next, I'm thinking about this splenomegaly, we could fit with our train of thought of like the infection or something affecting the reticular endothelial system, and why she has this splenomegaly. And I will review if she had that before or not. But yeah, it's a lot of things.
That was incredible how you were so smooth in articulating that. You realize you didn't even stop. You just shoo, like it was just so poetic. I have nothing to add to your reflections, and I think you're on the right track. At least that's it. I don't know if you're on the right track, to be honest with you. But I know you're on the same track that I am. That was incredible. Absolutely incredible. Noah, just one clarifying question. Are these masses in her native kidneys or transplanted kidneys?
That's a good question. I have the
Yeah, I'll tell you why I'm asking, because I think that, you know, when you start to think about where a patient may get an infection from, or where a patient may get a cancer from, the latter question feels like a ridiculous question. Where do patients get cancer from? From themselves. But it's really important to be open to the possibility so soon after a transplant that the patient has a donor-derived cancer. And when cancers pop up right out of the blue, remember that the transplanted organ may have contained microscopic tumor that, in the context of immunosuppression, has blossomed. And the same is true for infections. So there have been crazy case reports of tuberculosis, cryptococcus, toxoplasmosis, all coming from the transplanted organ. So remember, we're putting a massive organ in somebody which could carry cancer or infection. So having that as an open thread of the possibility that it was the vector is really important. So yeah, no, I saw that you were unmuted. Go ahead.
Yeah, so it's in the native kidneys. So severe atrophy of both kidneys are two hyperattenuating lesions, one within each kidney measuring up to 0.7 centimeters in the right and 1.2 in the left. These were previously not hyperdense or non-contrast imaging and compatible with enhancing renal masses. And they did mention it was suspicious for RCC.
That's amazing. Okay, gotcha. Yeah, I think that, the fact that they're in the native kidneys and not in the transplanted kidney is very reassuring and reduces the probability that there's a vector, the transplant-related cancer. But yeah, I think, the landscape here is very interesting, Marcela, because you mentioned that when in a world of acute fever, you really have to focus on infection, and this is neutropenic fever. This is a medical emergency until proven otherwise. Though I think if the rate of pyogenic bacterial organisms and neutropenic fever outside chemotherapy-related neutropenia is much lower. And the reason for that is that chemotherapy-induced neutropenia doesn't just cause neutropenia, but it causes unrecognized or recognized mucositis in the GI tract. And so the reason febrile neutropenia is such a high-risk condition is both that the chemotherapy damages the GI lining and the patient has no immune system. And here, we have no reason to believe that the GI lining is compromised, and so the risk of severe neutropenic illness in these patients is much lower. So here, unlike the circumstance of traditional neutropenic fever, chemotherapy induced, where we know why the patient is neutropenic, we just have to figure out why they have a fever. Here, unfortunately, we have to figure out why the patient has a fever and why they're neutropenic. But you made the observation, this isn't just neutropenia, this is pancytopenia. And I think the approach to pancytopenia is exactly what you outlined it to be, which is there a systemic infection? Is there a specific substance or medication? Is there a space-occupying process that's infiltrating the bone marrow? And I think we have to go on that journey together. And that journey will be illuminated significantly by the peripheral smear and to help us figure out like what the peripheral smear is actually showing. So I agree with you. I think the next steps are to overlay broad spectrum antibiotics in this patient and to start to say, this is an inflammatory syndrome featuring the hematological system with pancytopenia and splenomegaly with a little bit of a twist. And the twist is that the patient has bilateral renal masses that appear to be enhancing and suggestive of RCC. And so I think I would really focus on the hematological elements because I can imagine we can make a lot of progress on those. And we'll have to come back and contend with, well, what do we do about these renal masses and are they relevant? So right there with you, and I'm curious what Noah has in store for us next.
Beautiful discussion. One thing I really appreciated about this case was how systematic and methodical the admitting team was in approaching her case. She has a lot going on, but they did their due diligence for every single finding. So for the neutropenic fever, they started her on broad antibiotics. They consulted ID, given the complexity of the case and her being a transplant patient. For the anemia, they triggered, the standard anemia workup, even though it was kind of at her baseline. So they got for her retic count, which was elevated, ferritin, which was 10,000, hapto, which was undetectable, LDH, which was 752, DAT, which was negative. The peripheral smear did not show any schistocytes. It also didn't show any blasts or any findings for that matter. It did show, some toxic-looking neutrophils, evidence of marrow stress. That's what Heme said. They also consulted Room for this history of lupus, and Room recommended C3, C4, and double-stranded DNA in the UA, which were all negative, very suggestive, like lupus not flaring up. And then they also consulted urology, and I feel like this is something that happens not infrequently here in my hospital, we'll find a mass, and neurology will say, oh, this outpatient follow-up in like 3 months with repeat imaging. And that's what they said. They said it was kind of unusual to be bilateral. It wasn't super concerning. They think it's nothing to do with this presentation because they think it's like pretty localized, no evidence of metastasis. And there's like very, very, very rare cases of paraneoplastic syndromes, which could look like this, but it's like incredibly rare. So they were not concerned at all.
Oh, wow. All right, Marcela, what happened to your thinking there? What progress have you made?
So, Noah, can you repeat how much was the ferritin? You said 10K.
It was 10,000, and then they trended it. It trended up to 16,000 the next day.
Okay. So, I think like we were discussing before, I'm kind of like trying to focus on the pancytopenia and like the spleen, and now we have this very elevated ferritin and the LDH. So one thing that it's kind of like I'm trying to understand, her kidney function is like normal at baseline, and her liver function is also normal, which is curious to me. I would expect maybe that to be I don't know, maybe having like a liver affected, so I'm thinking why the liver is not affected. But anyway, I think at this point, I would, and I hope I did that, I would go back and talk to the patient and get a very good exposure history for her. And then I'll start thinking again about like her bone marrow, especially with this ferritin and the LDH. And start thinking about the possible type of infections. So we were thinking about like viral. It looks more, I think, more like viral or like fungal disease because of this ferritin, LDH. At the same time, I am concerned about bacteria, but not as much as I would be about other possibilities. And then next, I would start thinking about autoimmune disease. It seems that rheumatology doesn't think that it could be like a lupus flare, but could she have something else? And after that, I also started thinking if she would be going towards a complication of that, like HLH, because of her ferritin, because of her LDH. So I would have a close eye into that and keep trending those labs and talk to the specialist to see where are their thoughts.
Yeah, outstanding, Marcela. I'm right there with you. I love that you labeled HLH as a complication, not a diagnosis. And I think that HLH is just like neutrophilia. Of course, it means there's something bad going on in a patient. And sometimes you need to shut down the response with steroids or more robust processes, but like you really have to think about what the underlying cause is. And I think this case is very murky, Marcela, because you might look at the retic count and the haptoglobin and say that this patient has anemia, reticulocytosis, and undetectable haptoglobin. Are they hemolyzing? And I think that's an interesting conclusion to come to, because the counter arguments to hemolysis are the bilirubin is normal, the UA is normal, and the patient does not have any evidence of hemolysis or any morphological changes in her red blood cells to suggest hemolysis. And so you might ask, well, what does that really fundamentally mean? And I think in the absence of liver disease, an undetectable haptoglobin means that there's plasma-free hemoglobin. And the reticulocytes being elevated to compensate for that certainly suggests so. And so here you might say, okay, well, is their patient having just primary intravascular, low-grade intravascular hemolysis, which in the context of fever would really prioritize evaluation for babesia or malaria. And here in this patient who has been transplanted and received blood, you really would wonder about that possibility. So I would really try to make sure that in addition to the viral PCRs we've sent off, to send off PCRs for those specific organisms or testing for those specific organisms. But I think the validity, the possibility of those infections in this context is not high enough to anchor in that space. And I think the paradox that is set up here is that HLH by definition is really a cytopenia driven by macrophages engulfing marrow cells, and by definition should result in dysfunction of the marrow. And so I see a little bit of a tension here between the working hypothesis, this is HLH-like inflammation, with the fact that the reticulocyte count is elevated. And so I feel like that's an interesting space to try to explore. But at the end of the day, I think we ask ourselves what infections are compatible with this process. And I think you named them all. There's a subset of viral infections that can do it, namely CMV and EBV, a whole slew of granulomatous infections, including mycobacterial and fungal infections. And then, of course, as we just alluded to, some parasitic infections like malaria, babesia, and leishmaniasis. So, I'm rambling because I think that the problem space here isn't fully defined. We have a very prominent hematological signature, and we're headed towards the operating framework of HLH-like inflammation, which has us initially focusing in on infections, but also being open to the possibility eventually that a liquid greater than solid tumor is driving all of this. And so how do you make progress in a case like this now? I think that it really hinges on your extensive testing of the blood. But at some point, you're going to need tissue to figure out where this process is. And the only site of tissue that we've seen so far outside the bone marrow is the kidney. And so I would be struggling in real life to figure out, hey, who's going to help me crack this case? Is it the lab when they call me with a positive PCR? Is it the hematopathologist when they call me with a positive bone marrow biopsy? Or is it going to be leaning in on urology again to say, hey, this case is really not going anywhere. What are these renal masses? And I think any of those paths are possible. I don't know what other clues we can collect except to emphasize that a negative CT chest really reduces the probability of, not eliminates, but reduces the probability of TB, histo, and all the granulomatous infections that tend to leave a signature in the chest before they disseminate. So a very, very interesting case where the core issue is not yet fundamentally clear. And I see blood, marrow, and kidney as potential paths to help us get clarity. I know what you got.
Awesome. So that's what I did. There's like this huge infectious workup. I'm sorry for whoever's scribing. I'm just gonna paste in a chat and I'll read it off for people who are listening. HIV, hepatitis B, hepatitis C, EBV, RPR, CMV, blood cultures, acute hepatitis panel, Rocky Mountain Spotted Fever, Ehrlichia, urine histo, parvo, serum histo, serum HSV, crypto, stool, ova and parasite, mold blood cultures, AFB blood cultures, coccidioblasto, galactomannan, toxoplasma PCR, serum adenovirus, Bartonella antibodies, Heartland and Bourbon virus serology and PCR were also sent out, which are also negative. So pretty extensive infectious workup. They also got a PET scan, which was unrevealing. It only showed hypermetabolic bone marrow, but this was after they gave the patient G-CSF for the neutropenia. So it's kind of an expected finding. AVRA demonstrated the renal masses, but nothing else. They also pursued the bone marrow biopsy, which showed hypocellular bone marrow with maturing multilineage hematopoiesis, atypia, no increased blasts, no significant monoclonal cell populations, rare cells compatible with hematophagocytosis. They also did FISH and cytogenetics, which were all negative for malignancy in the bone marrow. So the patient received broad spectrum antibiotics for a couple days. She got a couple days of Doxy-2 before the Ehrlichia and Rocky Mountain fever came back. She was still having fevers. She got the G-CSF, had improvement in neutropenia, and then hematology together with rheumatology decided to do a DEX taper for her to kind of reduce this inflammation. She never ended up having significant organ dysfunction, which was good. Her LFTs did trend up slightly, but they were both under hundreds. And after a week and a half of hospitalization, she had like significant clinical improvement. And then they decided to discharge her. And the discharge summary said, discharged with no answers. She had improvement after CSF, antibiotics, short text course, Bactrim, and mycophenolate to be unheld 1 week after discharge. I'm going to give more information because I know Marcela has clinic patients to see soon. So the DEX course ended a couple days after discharge, and then soon after her symptoms recurred. Fevers, constitutional symptoms, arthralgias, bone pains. The MMF was resumed after the symptoms came back, and then she decided to represent to the hospital. She was again treated with IV steroids, empiric antibiotics. ID actually suggested repeating Bartonella, Francisella, and Rickettsia antibodies, especially because she got plaques a couple weeks before the initial presentation. So they were concerned that could be a false negative due to the plaques. They also got a repeat serological profile for dimorphic mycosis, and those were all negative. They decided to get a spleen biopsy. They went after the spleen, which was unrevealing, just showed some extra marrow hematopoiesis. They sent the spleen for culture, AFP culture, and 16S genetics. She was then discharged on a pred taper. After that, she refevered 12 days after discharge, kind of after the pred taper was getting closer to the end. So she represented again. They obtained HHV 6 and 8 serum DNA PCR, like Andrew was suggesting. They reconsulted urology, Andrew, and urology was like, no, this is not the kidneys. You guys are like looking in the wrong place. They were very confident, and they're refusing to biopsy or do anything inpatient for the kidneys. Rheumatology was very involved then for like further suggestions of immunosuppressions since they wanted to spare her the steroids. So they started her anakinra, 100 milligrams daily. She had good clinical response, but then had an infusion reaction. So they actually changed it to tocilizumab. And then after the tocilizumab was started, she had worsening thrombocytopenia. They started rituximab for presumed ITP. She had worsening leukocytosis a couple days later, tachycardia, kind of tanked clinically, went to the MICU, was concerned for sepsis. They re-imaged her and they saw a new lower lobe infiltrate, wedge-shaped spleen infarct. I know it's a lot of information. I think this case is getting close to an end, and I'll review the final diagnosis in the next aliquot.
All right, Marcela. How would you
Oh
summarize
gosh.
information?
Yes. Oh gosh, a lot of information. So to be honest, at this point, what would happen is that I would call my friend Kirtan and I would ask for a Kirtan consult. That's what happens in reality.
I love that.
But besides calling Kirtan, what I would do is that I would kind of like take a time and seat and understand um, all the workup, what was done, and what could be kind of like a false negative. Like I did wanted to repeat some serologies, but at this point, I'm trying to use the treatment that we did in the first few weeks to use as like a diagnostic clue. So she's getting better with like steroids and with immunosuppression. Um, and why is that happening? So that kind of makes me think more towards an autoimmune process happening, or like even a malignancy process happening. But it seems that for now, the bone marrow biopsy was kind of reassuring for that. So I was thinking more about autoimmune, what is happening, why she's getting better with steroids, and why she got better with like an IL-1 inhibitor. And I would be thinking about autoimmune, or maybe an infection that's very like atypical and that maybe trigger an autoimmune response or something, like we were talking about like Castleman's or the HLH or something related to that. So honestly, that's what I was thinking about doing, and I would talk to room and talk to ID and put them on a chat and see if they could talk to each other and figure out how we could help this patient.
Yeah, I'm right there with you. I think the only pervasive feature of this disease is how profoundly affected the hematological system is. I think if you put the urological things aside for a moment and trust in the expertise of your urology colleagues, really, this is a hectic inflammatory hematological syndrome. And what's really fascinating is it doesn't seem to have lymphadenopathy as a feature of it, which I would say is a powerful clue because that's the only thing that is universal about Castleman's disease or multicentric Castleman's disease is literally 100% of patients have lymphadenopathy. So thankfully we can put that concern to aside and really start to say, well, what is key here? And I think for me, no, I just want to clarify, her bone marrow biopsy, was it hypo or hypercellular?
Hypo.
Okay, that's very helpful. And I think that poor Lyra, she just woke up from a nap and has described this case. Oh my gosh. Yeah, I think if you ask yourself, what is the differential diagnosis for a hypocellular bone marrow? And you might say, well, I'm not sure what the value of that exercise is because most of the time the marrow shuts down in the face of so many insults, including medications like the mycophenolate, which the patient was stopped on, or viral infections like parvovirus and CMV, which the patient was tested for. And so fundamentally, when a marrow is hypocellular, it's often because of an extrinsic insult causing the bone marrow to shut down. But when you look very, very hard for said extrinsic insult and you find nothing, you have to ask yourself, is there fundamentally something wrong with the bone marrow? And the most common disorder to cause a most common disorders to cause a hypocellular marrow are aplastic anemia and myelodysplasia. And I think there's many reasons to doubt those diagnoses, but those diagnoses, especially myelodysplasia, comes with cytogenetic changes, so there will be mutations in the bone marrow, and aplastic anemia also has some characteristic changes. I think in this context, you might have to worry about a really rare possibility, but it's crossing my mind, which is what's called transfusion-associated graft versus host disease. And the reason I would be thinking about that is, unfortunately, it really is in this kind of patient population where you get a hectic inflammatory response to foreign T. So what happens in transfusion graft versus host disease is you have T cells that are in the blood that has been transfused, and they start to cause chaos in an immunosuppressed host who cannot clear those T cells. And what's really distinct about transfusion-associated graft versus host disease is a very, very high tropism for the bone marrow to cause a very hectic cytopenic syndrome that we're seeing before us, with usually the clues of graft versus host disease in other spaces. But I think that would be something that I would be crossing my mind, and close analysis of the bone marrow and flow cytometry are really key. And the only hope of cure for transfusion-associated graft versus host disease is a stem cell transplant. And so I'm very, very perplexed. I'm worried about this patient, and I think I'm not really sure how to make progress outside of reassessing the bone marrow and connecting with urology again to biopsy these kidney masses. So yeah, I think, Marcela, where I would be at is we have an unexplained syndrome, and the fundamental question is it really unexplained, or is it explained by an unusual manifestation in an organ we've been ignoring so far, the kidneys? So essentially, really, is urology right or wrong? And if they're wrong, I think that tissue will help us probably diagnose at this point a hematological malignancy affecting both kidneys. If they're right, then I think we probably have a subradiological process, in which case analyzing the possibility that this is a missed infection, very thorough workup, missed cancer, where else do you biopsy? And then that's where I would visit the possibility of transfusion-associated graft versus host disease. I've only heard about one case of it. It was very, very similar to this and very, very devastating. Any final thoughts you want to sprinkle in, Marcela, before we hear from Noah?
No, I'm just really curious to know and really eager to learn more. And I'll be talking about that with Noah later today too.
Okay, so they got a repeat PET scan for her. It showed interval increase in size and avidity of multiple lymph nodes, uh, both above and below the diaphragm. But they called it like reactive lymph nodes. It wasn't big enough to be worrisome. They also saw some periportal lymph nodes. And at this point, they were like, okay, let's get something. Let's get another piece of tissue. They did a HD with endoscopic ultrasound and biopsy of those periportal lymph nodes, which was actually non-diagnostic. They reconsulted urology, and they're refusing to do any biopsy of the masses. She started having some back pain, so they got a lumbar MRI, which showed scattered numerous tiny enhancing foci in the vertebral bodies and posterior elements, as well as mild edema in the interspinous process. And then they were like, oh my God, what is going on in this patient? No one knows. Room was considering Castleman's disease. They were considering adult onset Still's disease. They were considering a syndrome called autoinflammatory syndrome from mycophenolate. In some patients, you can have a paradoxical reaction. We also sent out the INVITE panel for the genetic autoinflammatory syndromes, which can cause kind of a slow burn HLH type of picture. They were considering doing a repeat bone marrow biopsy, and they were going to get her on schedule when the 16S genetics from the spleen comes back. And it comes back positive for Bartonella. So they send the Bartonella PCR in the blood, and it also comes back positive. Her echo was clean. She was started getting doxycycline, and all her symptoms resolved.
Bartonella snuck up on us, Marcela. What do you think?
Wow, I'm like amazed. Whoa, that's really cool. I'm glad that we got that diagnosis for the patient, and I was definitely not expecting that. And I feel that sometimes when we do this like very broad idea workup, we try so many things, and then we're like, okay, is this like a real diagnosis? Like, is this a real test, or is it false positive, false negative? And yeah, well, a really, really good case. Thank you so much, Noah. That was amazing. Thank you so much, Rabih. I learned a lot.
The learning is going to be endless in this case. Noah, just to clarify, when we were discussing the negative testing for Bartonella earlier on, what was that testing?
So they actually repeated the Bartonella antibodies 4 times for this patient.
I see.
And all 4 times it was negative.
Fascinating, fascinating. Yeah, I think as Marcela had warned, the power of antibody testing and the validity of antibody testing in an immunosuppressed patient has to be interpreted with caution. And I think fundamentally, you ask yourself, is this case compatible with invasive Bartonellosis? And the answer is absolutely yes. I think a febrile wasting syndrome centered around the spleen and eventually lymph nodes is a really, really good fit for Bartonella. As are the bone lesions that then subsequently evolved. I think I think it's absolutely fascinating to reflect on the fact that the patient got better with steroids temporarily, that she had HLH-like physiology. I'd be really curious to see if those enhancing renal masses are actually just the vascular manifestation of Bartonella. It's very, very well described to get enhancing lesions in the liver, pileosis hepatis as an example. So I wonder if bilateral synchronous RCCs is equally, if not less probable than Bartonella, vascular manifestation of Bartonella. I'd be really, really curious to see that. Oh yeah, I don't think there's enough time and enough. I haven't processed this case enough. It's such a complicated one. So instead of me doing so, I'd love to learn from you, Noah. Like, how did you digest this case? What were the clues in retrospect? What did you take away from it?
It was an insane case. Like I remember rounding, and I think this case had so many good learning paths for me. this patient with this initial inflammatory syndrome and pancytopenia, getting the ferritin very early was game changing. It was like really quick to identify the HLH physiology. I learned a ton about autoimmune neutropenia, Felty syndrome, and their specific mutations which are associated with both lupus and autoimmune neutropenia, and the LGL that Mark mentioned in the chat. And it was just very interesting to see again and again the tests fooling us, because we don't really think that the test can be like a false negative, right? This patient was getting a lot of immunosuppression. She got the Plex, she got the IVIG, and I do think that the main drivers of her symptoms weren't from the Bartonella itself, was just kind of the Bartonella insult to her autoimmune system. And that's why she got so much better with immunosuppression and why it was so hard to catch the bug. It was a wonderful case and a wonderful discussion.
I think that the fact that this takes you to the end of the diagnostic sphere is really, really, yeah, it's very, very enriching. A lot to digest on this case. I can't wait to reflect on this case with you all in the academy and do a little reflection session. I do not envy Selson, who has the unenviable task of summarizing the teaching in this case. I think there's a lot of bread and butter stuff, but Mike, over to you, Selson.
Okay, I'm really lost after Noah's case, but it was a really good one and great discussion, Marcella and Dr. Rabi. So we started the case with a 30-year-old female who presents to the ED with fever of 5 to 7 days duration. So to approach the chief complaint, we have to define our problem. Is it like true fever, or is the patient having like hyperthermia and the other causes of it? And we can use the IMAID mnemonic to help us, which stands for infection, malignancy, autoimmune, drugs, and endocrine causes. And you also have to look at the associated symptoms, the time course, any exposures, and assess the immune status of the patient and to know our host. And in our case, our host was immunosuppressed. So we have to also assess, is our patient stable, or she's having any kind of dysfunction? And Dr. Rabi taught us a way to assess for that is to see if the patient is able to walk, eat, and talk. And another pearl from today, I think one of the most important pearls is the workup for the immunocompromised patients. And Dr. Rabi told us that usually the workup is similar to immunocompetent patients, but we also have to keep in mind that the range of possible viruses is much broader, including viruses that are not localizing to a specific mucosal site. So we have to keep that in mind. And the absence of focality in history or examination doesn't always rule out the possibility of a focal infection, and we have to lean on radiology to help us rule this out. And another thing is that if we have renal masses in a patient with a history of renal transplant, we have to see are the masses in the transplanted kidney or in the native kidneys, because in the transplanted kidneys, we have to keep in mind the possibility of having microscopic tumor. And in cases of immunosuppression that has grown and blossomed, so it's called like donor-derived cancer. So always think about cancer versus infection in these kind of situations. And another thing is if we're having fever and intravascular hemolysis, we have to keep in mind to test for babesiosis and malaria. And another thing is the transfusion-related graft versus host disease, is that we have to keep that possibility in mind. And it's like we have T cells that have high tropism to the bone marrow that can cause cytopenias, I think. Thank you. Those are my teaching points.
I really commend you for keeping this fundamental bread and butter, and really I don't think I'd be able to do any better of a job in the teaching points of such a complicated case. So thank you so much, Selson. A huge shout out to the WashU team and Noah and Marcella for an incredible hour. Really, really enjoyed sharing this space with you, and thank you both for such a wonderful time. And a big fist bump to Lyra to waking up and having to do this. Thank you all for an awesome time, and I look forward to seeing you next time. Bye, guys.